you ask our patients and families, and this is on both sides of the ocean, we're not delivering the basics of care, and in a very complex system. Patients in many ways are from the outside looking in, and it's very, very complex. No industry has survived without focusing on the needs, wants, and desires of their end users. And I'll challenge all of us to say, that has that happened in healthcare? It's really been lost along the way. We must begin to listen to our patients and families and caregivers as our end users in the delivery of care, and actually engage them in the design of the new approaches. As practicing physicians and as practicing caregivers, we have clinical and process. That's the things like evidence-based medicine, clinical pathways. But what are the design sciences and experience-based design? Well, by definition, that designing services, interactions, processes, and environments for the complete experience, making it better for the end user, expanding on but not replacing the concept of clinical sciences and process, and probably very importantly, providing tools, in many ways, different tools and different metrics than what we're used to first understand and then act. How many times have we attempted to export best practices to no avail? So how does this experience-based design, what does it teach us in healthcare? First rule, we should never be a service line in healthcare, because the value is that we stage experiences and we guide transformations of our patients and families. It also takes you one step further and partners with patients and families, because when transformations occur, patients are engaged in change by definition. Secondly, it forces us then to look at the whole experience, the full cycle of care. There's a continuum of engagement and partnership with patients. So the most primitive form is many times just complaining and listening to complaints. At some point, you not only listen to the complaints, but you react to the complaints. That's a form of co-design. Service recovery, a form of co-design, but it's the most primitive form of co-design. Then you move into the stage of consulting and advising, like patient and family advisory councils, more active participation. But there's another stage in experience-based co-design where patients and families literally are part of the design process. We need to have simple solutions in our complex system, and experience-based design in the design sciences actually provides that tool. Number one, it's a methodology. It's a scientific process. It's what we do every day. The second, it must include co-design, and that's patients and families and caregivers as well. And thirdly, and probably more importantly, is that we all know there's hurdles. And the design sciences and experience-based design sets a structure to allow us to overcome hurdles. So we have to go from any current state to what we call the ideal experience. And that's what the design sciences and the methodologies provide. And one of the ones that we've been working on is called the Patient and Family-Centered Care Methodology and Practice. In the end, our view is everyone is a caregiver. Titles don't matter anymore. So a caregiver in PFCC terms is any person within a care setting whose work touches a patient's or family's experience. That is certainly the traditional healthcare providers like doctors and nurses and aides and all, but it's also the parking guy, it's also the CEO, it's also finance. Next, and this is part of the fun of it, is one of the first homework items of your working group is to develop a shared vision of the ideal care experience for patients and families. And by this time, you will have had lots of interaction with patients and families, and many times our groups actually have patients and families participate in the development of this. We actually have had some groups that were the leaders were a little reluctant to allow their caregivers to do it. But you would be amazed how many of our working groups have achieved the ideal in a very short amount of time. Remember, we reevaluate. We never reach the ideal. We're always working towards the ideal, and the ideal always is changing. We use stories. Stories, as you know, are part of our social fabric. Shadowing, I will tell you up front, is not a secret shopper program. If anything, it's the other end, because it's an active participation of a shadower in a patient and family unit with lots of positive unintended consequences. It's really walking the walk of patients and families. You shadow the patients and family through the selected care experience that you're looking at, as well as recording observations and insights. And I guarantee you it's the highest impact for dollars and for time spent. But the missing link, in my view, has been how do we take that energy, that information, and funnel it back into a system for change? One of the hurdles I've heard for patient and family-centered care is, oh, how are we going to get patients and families involved in the process? It's us. You go to your own institution. We as caregivers are tremendously successful at separating ourselves as patients and families. Meanwhile, we are patients and families. There's an untapped resource there for co-design within the walls of our own institution. We test ideas. We test them. We validate them. Sometimes they don't work. We'll go back and do it again. We eventually get to a process that works, and then we operationalize it. So it goes from a pilot project to a tested mode of delivery to an operationalized within the facility. So a couple quick examples. Near and dear to my heart is our own center at the Bone and Joint Center. The focus is on hip-knee replacement for patients with hip and knee arthritis and spine surgery. The end result, I won't talk about the journey, but the end result, we have one of the highest surgical volumes, inpatient surgical volumes in the entire UPMC health system, which is made up of 22 hospitals in Western Pennsylvania. We have discharges to home over 90% of the time with the lowest length of stay. By all quality measures, as far as outcomes, readmission rate, transfusion rates, infection rates, all best within the system and highest in the country. We have the tools to begin to develop new systems, but we must begin to place the care experience of patients and families at the center and go further and partner with them in the co-design process and place that on the same footing as process and clinical goals so that we can transform the system by design. We don't know the final answers, but approaches like what we're talking about can get all of us heading in the right direction and, most importantly, adapt to our changing environment. Next time you talk about, if someone says, if I ran that hospital, the answer should be, number one, we have to view all care through the eyes of patients and families, and we have to partner with patients and families and caregivers to really look at the directions we need to go. Thank you very much.